Hi, I'm Dr. Wende. I'm a senior pain physician in Hadassah University Teaching Hospital for those who don't know me, and I lead the treatment of musculoskeletal pain in the pain unit. So today I'm going to be talking about the Lumbo-Sacro-Iliac complex. The reason I call it that is because it's all connected, and I'm going to stress this again and again and again. This is the 6th lecture of the theoretical part of the course, our prolotherapy course. The practical part will be in May. And so all the theoretical lectures are on Zoom, usually on Sunday nights. Basically, all the principles discussed here can actually be applied also to the treatment using prolotherapy, using platelet-rich plasma injections. Both are anabolic. We both want to incite an anabolic response to strengthen tissues, whether it's cartilage, whether it's collagen tissue. In this case, most of the treatments we use here are for, in this particular lecture, are for the strengthening the ligaments. So if you want to get a very good long-term therapeutic result, we have to aim properly. And so we have to understand, and this applies to the treatment of any condition anywhere in the body. If you want to have a successful long-term therapeutic result, you have to do usually a methodical, comprehensive evaluation, especially when the problem is chronic, and especially when you're dealing with musculoskeletal disorders, because when we have a chronic problem, then areas compensate one for the other. And so you have extra stresses falling on other areas that are compensating. And therefore, if you want a good result, you must do, first of all, a methodical, comprehensive evaluation, and the treatment must be accordingly methodical and comprehensive. So you have to understand that stresses that fall on an area, they fall on an area not on just one little supraspinalis tendon, or not just on the knee joint or the sacroiliac joint itself, or on one particular ligament, on the Achilles tendon. They fall on a region. It may be that one tendon or one ligament will succumb first, but whether the stresses come as a result of trauma from a fall, or a chronic stress, which is resulting from faulty ergonomics or faulty postures, these fall on the region. Now, we can't really undo the stresses that come from a fall, from trauma, and we can't always change the posture, especially patients who are getting older and they've got sort of fixed deformities. But we can at least try and strengthen the whole region so that these will be able to withstand the forces better and falling on them. So we must address a functional unit, and I'm not talking about a functional muscular unit where muscles are acting as agonists to each other. But I'm talking in this case, when we're talking about the Lumbo-Sacro-Iliac complex, I'm talking about the lumbar spine, the sacroiliac joints, the sacroiliac ligaments, the gluteal muscles, the hip joints. Everything functions together, and dysfunction of one substructure is going to affect the function of the other. So when we treat, we don't have to necessarily treat all these structures in one treatment, of course not. And we don't have to treat all these structures with prolotherapy or platelet-rich plasma. We can use physiotherapy, muscles strengthening, all sorts of particular exercises, and all sorts of other treatments. But we have to address this whole region, especially if there are other areas that are pathological, in order to get good long-term results. So we think rehabilitatively, not just one shot. And we have to focus on all these extra stresses. Now, there are several myths regarding sacroiliac pain and dysfunction. And I want to dispel these myths one by one throughout the lecture. I'll have to dispel it throughout the lecture in order to explain why these, the pathology and the function, so that you can understand why these myths are really myths. So the lecture may be a little bit disorganized, but that's how I can only dispel the myths one as I go through the lecture. So the myth number one is, as the orthopods often say, there is no movement or minimal movement in the sacroiliac joints. So big deal, no problem fixating it, arthrodesing it, abracadabra, the pain will go away. Myth number two, sacroiliac joint pain refers to the buttocks and not far beyond. In most cases, may be, but it's not a golden rule. Myth number three, sacroiliac joint movement can be palpated, sometimes but not reliably, which we will discuss. And myth number four, the gold standard for diagnosis of sacroiliac joint pain is with intra-articular injection of local anesthetic to see if that relieves the pain. And if it does relieve the pain arises from the joint. If it doesn't relieve the pain has nothing to do with the sacroiliac region. The second figure that I'm going to be discussing throughout this lecture is why the sacroiliac joints and ligaments are so vulnerable to dysfunction, especially in humans. And again, as I'm discussing the anatomy and the biomechanics, etc., then you will understand more and more why the sacroiliac ligaments and joints are so dysfunctional, are so vulnerable to dysfunction, and you'll understand why we should really be paying attention to this pathology as a more common cause of low back pain. So the lecture outline, first of all, we talk about the anatomy, the biomechanics, movement, function of the joints, the symptomatology, surface anatomy, the points to inject, and I'll be showing a few ultrasound pictures, although this is just a teaser. Most of it will be, I'll give these ultrasound pictures more in the practical part of the course. So the question why the sacroiliac complex is so vulnerable to strain, first reason is we're not dogs or horses or even monkeys that walk on four limbs and land on two when they run. We're bipedal, so we walk on two, actually for part of the gait at least, and landing on one the rest of it. But when we run, we're landing, all our weight falls on that one lower limb. So there's a lot of strain on that landing joint, landing limb. There's a concept coined by a famous architect by the name of Buckminster Fuller called tensegrity. And tensegrity is the concept of tension and integrity together, or tension and compressive forces. So if you look at this structure on the right-hand side, you'll see a structure comprised of a whole lot of rods connected with these elastic bands. And if you're going to pull on one, you can imagine, if you're going to pull on one of those elastic bands, that will deform the whole structure. So much so, like this is the sacroiliac region. It functions sort of like a basket, like you see down the bottom. And if you can imagine, if you pull on one of those strings there down the bottom, that will again deform much of the structure. So everything is really interconnected in function and must be coordinated for healthy function. Structures respond to mechanical forces in a balanced fashion. So sacroiliac function is inherently related to that of the hips, the lumbar spine, the gluteal muscles, the lateral and medial rotators of the hip, and also the abdominal muscles. And they have to really all be coordinated in order to maximize function. In terms of anatomy, the sacroiliac region is, we have the sacrum in between, and that joins up with the ilium. Now you can see that there's three bones that comprise this pelvic part of the bone, apart from the sacrum, the ilium, which provide the wings of the pelvis, the pubis bone down the front, with the pubic tubercle in front, the ischium behind. And what I found very interesting is that these bones all join up together right in the middle of the acetabulum, where the femoral head articulates. The greater sciatic foramen forms some sort of connection between the gluteal region and the thigh, with the piriformis muscle coming out, the sciatic nerve coming out, and several other nerves coming out. The lesser sciatic foramen allows communication with the pelvis and the perineum, between the pelvis and the perineum. And the obturator canal allows communication with the adductor region. So if you look at the sacroiliac joint, looking at it from in front, you can see here that the superior entrance to the joint is much wider than the inferior entrance to the joint. If you go to look from behind, from the posterior aspect, you can see that the inferior aspect of the entrance to the joint is wider posterior than it is anteriorly, but the superior entrance is even wider. And that's actually filled with a lot of ligaments. So this has a lot of ramifications as to what happens when we inject and how we choose our injection sites. You can see this entrance is much bigger on the oblique. You can see it's much wider here, all the way down than it is from the anterior aspect. So dispelling myth 1, the sacroiliac joint movement is small, but the sacroiliac joint movement is small, but significant, contrary to what the myth says. The sacroiliac ligaments have a very important role of shock absorption. So I'm going to demonstrate these movements here. And these movements here are, this is a clip showing the movement, but the movements are actually very much exaggerated to demonstrate the movements that occur in the joint. So here's the sacroiliac joint, nutation and counter nutation of the sacrum, and movement of the pelvis, pelvic bones, and again, the nutation is slightly more realistic range. And this is interesting, what happens with axial loading when you have a lot of load falling on the lumbosacral spine. You can see the effect of the ligaments that on the one hand allow the load to be transmitted, the forces to be transmitted down below, but on the other hand, allow minimal movement so as to maintain stability. Now this is a little clip showing the effect of the sacrum on the whole posture. And again, this is very much exaggerated, but just to demonstrate. Also in a lateral direction, can be related to a scoliosis. And this is a clip of the sacroiliac ligaments. But before I started, I want to show you you can see the ligaments coming from the posterior aspect. And here are the ligaments in the front of this whole region. And you can understand how if someone has a female patient has symphyolisis related to pregnancy, and that pubic symphysis is sort of going to be moving, it's not going to be stable, you can understand how that's going to rock and affect that whole structure. And it's no wonder so many of these patients have back pain relating to the sacroiliac ligaments back here. So here are the transverse process of L4-5 from here, to which attach the iliolumbar ligaments and connect to the anterior sacroiliac ligaments. Posteriorly, they come from the L4 and L5 transverse process and inserting on the iliac crest. Here are the interosseous sacroiliac ligaments, which are said to be the strongest in the body, although some people can contest this. And on the side, here are the posterior sacroiliac ligaments, which are slightly cut here, but they actually join the sacrotuberous ligament, which, as the name suggests, come from the sacrum and go all the way down to the ischial tuberosity. And the sacrotuberous ligaments are the longest ligaments in the body. Here are the sacroiliac ligaments in an anatomical diagram seen from the posterior aspect. So again, the L4 and the L5 transverse process. You can see the L5 transverse process is much longer and much bigger, and the iliolumbar ligament attaches to this and to here. So if you're going to inject, you want to inject here, and you want to inject the iliac crest. And these are probably the two most important areas to inject, especially the L5 section of the iliolumbar ligament, which is larger than the L4 component, and the sacroiliac interosseous ligaments. If you have to choose two areas, if you don't want to do much of a treatment on a patient, or they're scared, or they don't want to do many treatments or whatever, they don't want many injections, then these two injections are the most important, because this is very important for transmitting the load from the up and down the lumbar spine, from the lumbar spine to the sacrum and down and up, further up. And the sacroiliac ligaments, interosseous, are the strongest, and they play the most important role in this joint here. So here there's a sacrotuberous ligament connecting, so you can inject the edge of the sacrum here and the ischial tuberosity. In front of that, anterior to the sacrotuberous, is a sacrospinous ligament. The ligaments are weaker in females, especially in middle age, and especially in women who have had multiple pregnancies, due to the relaxin hormone that is weakening and stretching allowing these ligaments to be stretched for all these years. So the function of the ligaments is basically to limit the movement to the minimal amount that we have and provide stability. What I didn't say is that the iliolumbar ligament is extremely important to treat especially in patients who have chronic pain coming from the quadratus lumborum or quadratus lumborum trigger points. Many of you who have done the myofascial dry needling courses know how much symptomatology, what a distressing complaint patients have from quadratus lumborum trigger points. The quadratus lumborum inserts onto the transverse processes, onto the iliac crest, but it also inserts into the iliolumbar ligament. So if pain is going to persist or relapse all the time and improve with dry needling or injection, but we keep on relapsing, then consider injecting with an anabolic treatment the iliolumbar ligament. Looking in cross-section, we looked in just sort of vertically at all these ligaments, but if you can take a cross-section of these ligaments, okay, here is the taking various views of the region. So if we're taking sort of this view here, transverse view, from region of around S1, or the upper section of the posterior suprailiac spine, you can see here's the spinous process of the sacrum, or as otherwise called the median sacral crest. And here is the posterior suprailiac spine here. So there are various layers here. So here is the thoracolumbar fascia. Here are the posterior sacroiliac ligaments. Here down here are the sacroiliac interosseous ligaments. Here is the sacral foramen where you don't want to go, at least not inside. And here is the joint, the lateral sacral crest of the sacrum, and here is the joint here. So when I'm going to discuss how I'm going to inject that area towards the end when I'm presenting a lot of other ultrasound pictures. So what are the functions of the sacroiliac joint? So we know to link the lower extremity with the trunk, to transfer the load from the trunk by the iliac bones and the femurs down to the tibia and the feet, to shock absorb from the ground, to protect the internal organs, to enable childbirth, and most importantly, to provide stability. Now, the myth number one says that the joint moves so insignificantly, nothing will happen if you fuse it. The joint does move 2 to 4 millimeters or 1 to 4 degrees. So this is, any small change is very significant. If someone's only going to move 1 millimeter instead of 2 millimeters, that's a reduction of between 25 and 50%. So this movement is critical for shock absorption. Now, if you can imagine you're going for a run outside, and you're going to run on the road, on a paved road, and then you're going to go running on the grass, or even on an unpaved road with lots of little stones. You can know that those little stones that move just millimeters provide a lot of shock absorption. And it's healthier for our knees to run on an unpaved road or on the grass, or even better on the sand, even though it's so much more difficult than on a paved road. We know that if you're going to wear shoes that have a very soft, spongy sort of sole, that will provide a lot of shock absorption. And you can feel the difference when you wear those sort of shoes, and then all of a sudden you go back to sort of hard soled shoes. You definitely feel the difference of the impact on your lower limb when you're walking or running, when you change from normal shoes to softer shoes, or the other way around. Again, answering the question why the sacroiliac complex is so vulnerable to strain. No muscle really crosses the joint. The gluteus maximus slightly crosses the joint, but mainly with fascia. It doesn't really directly cross the joint properly. And so much of the stability relies on the ligaments. And so if the ligaments are dysfunctional, so are the gluteal muscles especially. Now that's only partially true. The muscles don't really directly cross the joint, but there's a lot of fascia that crosses the joints, from the multifidi, the erector spinae, the thoracolumbar fascia, as I've mentioned before, the transverse abdominal muscle fascia, the latissimus dorsi, the gluteal muscles, piriformis. They all help to stabilize the joint. And that's why it's so important for us to be coordinated. If you're going to have overdominant abdominal muscles and weaker muscles of the extensor erector spinae muscles, then that'll cause some sort of imbalance. The third reason that the sacroiliac joints are so vulnerable to strain is that the sacroiliac joint is the largest axial joint to withstand vertical forces. And yet it has a small surface area and a small volume, which I'm going to talk about in a second. So we've got a lot of stress pointing on a tiny area. And the fourth reason, adjacent section degeneration. If a patient has spine fusion, like here you have an L4, L5 spine fusion, that affects the joints above, the vertebrae above and the vertebrae below. So if someone has a particular an L5S1 joint fusion, but also an L4-5, that affects the joint, the areas below as well, and above. And the sacroiliac joints are really suffer the consequences, because it means you've got a lot more stress on those joints. You've got a lot more need for movement. You have, and it just provides more wear and causes more wear and tear, both of the joints and of the ligaments, stresses on the ligaments. Now, if a patient has spinal stenosis or just severe spondylosis of the lumbar spine, then as we age, we have less range of motion of the lumbar spine. And then the effect will be exactly the same as if we had a spine fusion. It may not be limited to one area, but we've got limited spine motion right throughout the spine. And then we're going to have a lot more stress on the sacroiliac region. So the patient will be much more vulnerable to develop sacroiliac osteoarthritis and sacroiliac ligament dysfunction. There's another thing that I didn't mention here. The facet joints are very, very important in the whole stability of this region. As we age, our discs become compressed more, which means the ligaments on the side, the facet joint capsules, sort of become more lax, or all the ligaments become more lax, which will allow in turn some sort of listhesis of one vertebra over the other, whether anterior posteriorly or laterally, which will mean that when the patient's ambulating, there will be more stretch on the nerves, which may explain why a lot of patients have neurogenic claudication when they're walking, but they don't necessarily have spinal stenosis as seen on the CT or the MRI. So that also explains why we'll get, so a lot of patients will have some sort of relative lack of stability in the lumbar spine, and that can also affect the sacroiliac joints. Sacroiliac joint fusion obviously will cause more strain on the lumbar spine and also on one side. So what are the symptoms of sacroiliac dysfunction? Well, we want to dispel the myth that sacroiliac refers pain basically just down to the buttocks and not far beyond. Well, true, in a study done by Slipman about 2 decades ago, 94% of patients were found to have pain relating to the buttocks, 70% to the lower back, but 14 to 26% to the groin. And 50% of the patients also radiated pain to the lower limb up to the knee. 28% of the patients radiated pain down below the knee, and 14% right up to the foot. So the pain radiating down the leg past the knee does not equal radicular pain. So we have to put sacroiliac dysfunction or osteoarthritis as one of our differential diagnoses in pain in patients that have pain radiating down the leg past the knee. And therefore, it's so important to do a methodical examination, including all the sacroiliac tests as much as we can. Paresthesias. Patients can have paresthesias, though not in the dermatomal distribution. The leg may give way. They may sometimes, rarely though, but sometimes patients feel that some sort of sensation of something giving way as they walk. Sense of instability. By the way, the differential diagnosis of that are trigger points in the gluteal, in the vastus medialis muscle, but patients will feel that coming from somewhere lower down. Pain may be worse by sitting for long periods of time, and pain also may be exacerbated by standing, which is logical because we learned how the sacroiliac joint functions for stability. So if they're not functioning properly, pain will be worse by standing. And also never to forget to ask our patients, our female patients who are during reproductive age, whether the pain is worse during or before menstruation or during pregnancies. So in summary from this area, pain referral from the ligaments The ligaments are a source of pain. Referral pain patterns depend on where you stimulate from, whether you inject with hypertonic saline or just with the needle and how big the needle is, how thick the needle is. And this may explain why people have got various referral patterns. The different studies show very different referral patterns. So from Hackett, done in the 1950s, pain referring from the iliolumbar ligament refers to the groin and to the genitalia, and may even be neuropathic in quality. So this is a differential diagnosis of neuropathic pain. Pain radiating down the whole back of the lower limb, right down to the heel from the sacrotuberous ligament. Now, don't be alarmed by this. These are Hackett's referral patterns, and they're not 100% absolute because, as I said, different researchers have found different results. But he's got basically everything here from the side during pain from the sciatic nerve and the sacrospinous ligament and sacrotuberous ligament somewhere. So, but what is important? So I'm just presenting this to show that people have different referral patterns. But what I usually use when I'm examining my patients is that I apply pressure to the different sacroiliac ligaments, and I see if any of them are tender. And if something is tender, I will continue pressing that point for 10 seconds to see if that reproduces or exacerbates the pain referral pattern down the leg. And so interesting, a lot of patients will say, oh, that hurts, take your hand off. And I'll say, 1 second, I'm holding this for 10 seconds. I want to see if that causes your pain to refer down the leg. And then all of a sudden, patients will say, wow, do that again. Now, this doctor is interested in my pain. Do that again. And it's very interesting. You can press on the sacroiliac ligament or the iliolumbar ligament, and you'll get different referral patterns, not necessarily abiding by these sort of referral patterns that I've depicted. So the sacroiliac physical tests, examination tests, Faber, which stands for flexion, abduction, external rotation of the hip. We put an extra E on the end because we apply this sort of extension momentum on the thigh. Thigh thrust, distraction, compression, Genslen, and sacral thrust. Each of them have a very low specificity, but combined together provide a much more sort of specific result, which I'm going to show you soon. You can look at these tests to view how they're done on YouTube. There are various little video clips that demonstrate how to do it if you want to know how to do it. Resisted hip abduction has been cited as I saw in one article, as one of the tests for sacroiliac function. It's not really for sacroiliac function. It tests the gluteus medius in particular out of the abductors, because the gluteus medius abducts the hip. So when we're testing it against resistance, often we get a pain in patients that have sacroiliac dysfunction. And it's not because it's a sacroiliac test, it just goes to show how much interconnected, how much intimately connected our gluteal muscle functions with the sacroiliac function. So I always test patients for resisted hip abduction, as well as doing the sacroiliac tests. And here is a study done by Laslett in 2005 showing that the more tests you do, the more that are positive and that are found to be positive, the more likely that patient does have sacroiliac dysfunction or sacroiliac osteoarthritis. It doesn't differentiate between the two. Myth number 3, if we're talking about physical examination, one can palpate sacroiliac joint movement, Gillette sign. Stand the patient on one leg, lift up the other to 90 degrees, an examiner standing from behind, palpating under the dimples, and just when a leg is lifted up, you see if there's any sacroiliac movement. It can be palpated, but it has a very poor reliability. And also one cannot consciously move the sacroiliac joint. Myth number 4. The myth says that sacroiliac intra-articular injection are the gold standard for diagnosis of sacroiliac pain. So this completely ignores ligament dysfunction being a source of the pain. It only relates to the sacroiliac joint. That's number 1. Number 2, a study that I read last week shows anatomy study of the sacroiliac joint shows that the average volume of the joint is 1.4 cc's. So if you're going to inject a volume of, let's say, 0.3 to 0.5 cc's of contrast material, and then 1 cc to half to 1 cc of local anesthetic and steroid, you're going to result in a total volume that exceeds the 1.4 cc's. And this injectate is likely to leak out through the ventral sacroiliac joint, ventral aspect, which has a weaker capsule than the posterior aspect, and therefore the injectate is likely to affect the ventral sacral nerve roots. So one will invariably get false positive results. So in other words, the sacroiliac intra-articular injections are not very specific for sacroiliac joint pathology, and definitely not for ligament pathology. Surface anatomy. If you're going to lie the patient on the tummy, usually put a pillow underneath the tummy to reduce the lordosis. Approximate surface anatomy markings, which can be changing depending on the lordosis, how much you can neutralize that, the size of the pillow, etc. But basically the iliac crests come to about L4 level. The thumbs meet at a slightly lower level, so that the thumbs meet at L4-5. The interspinous levels are usually at the level of the transverse processes. The L5 transverse process is slightly, it's a little bit too high here, but the L5 transverse process is slightly higher than the interspinous space. And the actual lumbo-sacral should be around here actually. The greater trochanter here, the edge of the sacrum, the ischial tuberosity. The PSIS is around the level of S2, S1 to 2. And these are the markings on a patient. They're not actually, they don't look very exact because the camera wasn't on top of the patient. So these sort of look sort of much smaller than what they are. But so here are the interspinous spaces, and here is the posterior suprailiac spine. Here is the edge of the sacrum, which looks much, much wider than what it is, bearing in mind that you've got a lot of fat there, sort of, so you tend to get a much wider border. Looking at the ultrasound images, this is the transverse view. So here is the spinous process, and here is the inferior articular process, the superior articular, and here is the facet joint on this side. Taken on the transverse view. This is the same cross-section view that I showed you before of this median sacral crest here, the spinous process, the posterior suprailiac spine here. So you can see the top level of fascia is the thoracolumbar fascia connecting the median sacral crest to the PSIS. And then down here are the posterior sacroiliac ligaments. And here is the sacroiliac interosseous ligaments here and here, down here. Here is the sacral foramen. So in this case, it'll be S1 because it's taken at the top level. intermediate sacral crest, and the lateral sacral crest. So between the lateral sacral crest and the ilium, you will see the joint. And you can see here, there's a much bigger dip here. This is sort of bone, and somewhere down here you'll find the joint going in here. So when I inject, I usually start here. If I go into the superior entrance, which is usually the case because I can get to the ligaments as well. So I start here medially, right over the spinous, the median sacral crest. And I'm going to go, first of all, to the PSIS. And I'm going to inject the attachment of the thoracolumbar fascia. And I'm going to go down and inject the attachments to the posterior sacroiliac ligaments, and then further down to the sacroiliac interosseous ligament. And then I'm going to go down into the joint and inject a little bit of volume into the joint. Not too much, because we know that it can leak out into the ventral nerve roots. And I've had patients, after injecting 2 cc's of solution, coming out saying that they can't walk, and I see that they have really numbed their nerves. That really exemplifies how the injectate can leak out. And then I inject the lateral sacral crest, and I also go into here to inject the rest of the sacroiliac interosseous ligament, the sacral attachment of the interosseous ligaments. So in one jab, I'm doing 1, 2, 3, 4, 5 injections. And this is really, and I'm going to inject about, apart from the joint, I'm going to inject about 0.3 cc's to 0.5 cc's at each spot. So here it is under ultrasound. This is one of the pictures I've taken. Here's the top of the posterior sacroiliac spine. I'm coming from this end. This is the median sacral crest around here. So it's the thoracolumbar fascia. And here are the posterior sacroiliac ligaments. Here's the sacroiliac interosseous ligament. And here is the joint, actually around here, coming around here. So, and here is the sacral foramen here, there. So I'm going to go here, and down here, and then down here, and into the joint, and then being very careful not to get into the sacral foramen here and into here. Here's from the other side, going to the joint. You can see that joint a little bit more clearly. Injecting the lower entrance to the joint has been found to be more reliable. The injectate spreads to the joint better. In the top area, as I said, a lot of it is ligament, so I'm not sure how much actually can get into the joint. So this is on this side is the other way around. This is the medial side, the medial sacral crest. Here is the S3 foramen, and here is the lateral sacral crest, and just here is the joint here. So what are the take-home messages? Okay, so first of all, if you come home with one idea, then it has to be, and it's something I've said over and over and over again, the lumbar spine, the sacral, the sacrum, the iliac areas, the gluteal muscles, and the hips all function together. And therefore, one must address, whether either with prolotherapy or other treatments, or platelet-rich plasma, or physical exercise, or physiotherapy, or whatever, we have to address this whole region. And it can be over a few treatments, but you've got to do it, you've got to address this whole region, especially if they have multiple regions that are pathological, if you want to get long-lasting results. When we treat with prolotherapy or PRP, then you get post-procedural pain that can be nothing. It can be in patients who are very hypervigilant and have a very low pain threshold, a week or more, but usually 3 days, 6 days, often less. I think 3 days to 6 days is a very, very conservative estimate. Remember that steroids are catabolic, and therefore steroids will neutralize the prolotherapy or the platelet-rich plasma treatments. So we want to avoid treatments, and if patients have had steroid injections 2 to 3 weeks before the treatment, then we should postpone that treatment. We want to strengthen the gluteal muscles after prolotherapy and or platelet-rich plasma has begun. And in a very good example, I like to prescribe this. I generally, when I prescribe exercises, I'm sort of pretty lazy myself in terms of not wanting to do too many exercises. Like I don't want to do one exercise for the gluteus medius and one for the gluteus minimus and one for the tensor fasciolata. I want to do an exercise that will strengthen everything. So here is a picture of someone standing on his one leg. The standing leg is slightly bent at the knee. It's not locked into extension. The lifted leg is flexed to 90 degrees. And that is strengthening all four muscles of the hip. The gluteus medius, which is the strongest abductor, the main abductor. Gluteus maximus, which also slightly abducts. The gluteus minimus and the tensor fasciolata. And if you want to have a little bit of fun and challenge your gluteal muscles even more, you can get your partner or a friend or one of your children and stand opposite you a couple of meters, a few meters, and take a ball and throw to them and take it and catch it without losing balance and wobbling all over the place. And that will challenge your muscles even more and you'll strengthen even more. So this exercise strengthens the muscles of the supporting standing hip. So thank you very much for listening. If you have any questions, you can write to my email, dowende@gmail.com. This is my website if you need to ask, look at anything, I have a bit more information there. So thank you, and I hope to see you at the course. Mm-hmm.